Yeah, so this is a phase 1 dose escalation study of fractionated dose-intense actinium-225J591 in metastatic castration-resistant prostate cancer. And so this drug is a PSMA-targeted radiotherapy. The J591 represents a monoclonal antibody that we developed at Cornell that has now been conjugated to a potent alpha emitter called actinium-225. For this phase 1 dose escalation study, we used a modified 3+3 dose escalation study. We initially started with 3 cohorts, and in dose escalation added a 4th cohort of intermediate dosage to determine as our primary objectives, our dose-limiting toxicity and our recommended phase 2 dose. And I'd like to discuss in brief our inclusion criteria. These patients all had metastatic CRPC based on prostate cancer working group 3, had adequate performance status of 0 to 2 by ECOG, and had all received at least one AR pathway inhibitor. Similarly, all patients were mandated to have prior exposure to taxane chemotherapies, excepting those patients who may have been ineligible or refusing. In this cohort, patients who had received PSMA radioligand therapy previously were excluded. Of note, this was a study amendment, so 2 patients included in these data had prior exposure to PSMA radioligand therapy. Adequate organ function was also required, and key exclusion criteria included prior receipt of non-PSMA beta emitters and any known history of myelodysplastic syndrome. With actinium-225J591 in this phase 1 dose escalation study, patients were treated with 2 doses, one in cycle 1 and cycle day 15, and the primary objective was to determine the dose-limiting toxicity, the DLT, and the recommended phase 2 dose. Before we get into the results, I think it's important to discuss how we defined a DLT. Our DLT period was the 8 weeks following the first dose, and a DLT was defined in that period of any patient who had grade 4 thrombocytopenia or grade 3 with major bleeding, grade 4 neutropenia, or any incidence of febrile neutropenia, and any grade 3 or worse non-hematologic toxicity. And finally, relevant to the study design, any grade 2 or worse adverse event attributable to the drug that delayed receipt of the second dose by greater than 2 weeks. So as the primary objective was DLT and recommend phase 2 dose, in keeping with phase 1 studies, the main goal is safety. And we observed at the highest dose cohort 3, 2 DLTs, a patient with grade 4 thrombocytopenia. I will note that this patient did have prior exposure to PSMA radioligand therapy, and a grade 2 thrombocytopenia that resulted in delay of the second dose by 2 weeks. Consequently, a 4th cohort of intermediate dose of 120 kilobecquerels per kilogram was added, and at this intermediate dose, 6 patients were treated in keeping with a 3+3 design, and only 1 DLT was observed. This patient had grade 4 thrombocytopenia that was transient. The patient's thrombocytopenia has resolved and his platelet count is normal today. From this, we chose as a recommended phase 2 dose 120 kilobecquerels per kilogram. In this phase 1 study, we also have preliminary evidence for efficacy, and this is represented both by PSA changes and CTC changes. Of the patients, the 23 patients evaluable for PSA change, 22 or nearly all patients had any PSA decline, with frequent best declines of 50% and 90%, including in 26% of patients. Of those patients with a 50% or better decline, 12 of the 16 are confirmed PSA 50s, and one of the remaining 4 patients is awaiting his confirmed PSA response. We also had CTC responses of 14 patients evaluable at baseline at 12 weeks for CTC counts or circulating tumor cell counts. We saw responses of any type in 79% of patients. Half of patients experienced a change from detectable to undetectable, and 2 of 5 patients who were unfavorable at baseline converted to favorable. To go back to the AEs just a bit, for hematologic AEs, we did observe, as mentioned, some grade 3, grade 4 neutropenia and thrombocytopenia. In the non-hematologic toxicities, we observed no high-grade toxicity, so no grade 3 or grade 4 non-hematologic toxicities. And among the most common non-hematologic toxicities, which were grade 1 and grade 2, were fatigue and pain flare. These results are important for our expansion into the phase 2, which we will do at the recommended phase 2 dose of 120 kilobecquerels per kilogram. Another important addition in the phase 2 is the addition of a radioligand therapy specific patient-reported outcome called FACT-RNT. This will focus on the symptoms and side effects and patients' experiences that might be unique or different receiving a drug like a radionuclide therapy as opposed to conventional chemotherapy or targeted drugs. And the second is the introduction of dosimetry. This will be using multi-time point SPECT to measure dose received rather than dose administered. Additionally, more broadly for J591, actinium-225 we have other ongoing studies in the phase 1 setting. One is for patients who have mandated that have had prior lutetium-177 radioligand therapy, and this is particularly relevant given the FDA approval of PSMA 617 conjugated to lutetium-177. We also have combination studies, so the same drug, actinium-225 in combination with a lutetium conjugated small molecule ligand called PSMA-INT. And also a randomized phase 2 study where every patient will be receiving ARSI and pembrolizumab in the pre-chemo setting for metastatic CRPC and will be randomized to receive or not receive one dose of actinium-225J591. More broadly speaking, now that PSMA radio-targeted therapy is part of the FDA approval, we'll be moving these drugs earlier and earlier into treatment. So rather than being always heavily pretreated, later stage, later line metastatic CRPC, we think there's real potential for these drugs, including with an alpha emitter like actinium in earlier stage patient care.